If not, it's a pleasure to introduce Sam Mann, who runs the diabetic retinopathy screening service in basically most of the south of England, and keeps our diabetics going very well along with my other colleagues. And she's talking about the classification of diabetic retinopathies and key risk factors. Thank you, Sam.
Thank you. So these are my no relevant financial disclosures. Sorry, moving on. I'm not moving on at the moment. Hang on, I'll just try this one. Okay, so you don't need to tell you that more than 60 million people with diabetes in Europe currently, a massive problem and important cause of blindness in the working age population, still number 2 in the UK population. Screening can allow the prompt identification and treatment to reduce the risk of sight loss. And as you all know, the main problem is you can have quite significant retinopathy, even advanced proliferative retinopathy with absolutely no symptoms. And it's only when you get the bleed into the vitreous that you start being aware of your disease. Classifications, there's a whole range of them. The AAO, EDTRS, UK. The UK has its own bespoke national screening programme classification. But all of these, it's essential to work out which stage the patient's at, so you can then give them some prognostic information about their progression to proliferative retinopathy. The one to remember is the severe non-proliferative retinopathy level, which in the English national programme is R2H, or high risk R2. 52% of these will then progress within a year to PDR, and this is the level which the patients are referred into the hospital eye service in the UK to allow more frequent monitoring. Don't forget that any stage they can have maculopathy, and then that needs to be monitored either in an OCT programme or in the hospital clinics. So how do we diagnose severe non-PDR then? This is the critical one. Don't forget the 4-2-1 rule. It's any one of these criteria. So 20 hemorrhages in each of the 4 quadrants. And this is the 2A photograph from the Wisconsin study. So all 4 quadrants, 20 hemorrhages at least, or we'll go on to the venous beading or, in 2 or more quadrants, or prominent ERMA, more than this photograph 8AA, which I'll show you, in 1 quadrant. So this is an example of venous beading. So if you see this level of venous beading in 2 or more quadrants of the eye, then you're going to diagnose severe non-proliferative. Don't forget the veins are very vulnerable in ischemia, and it's ischemia that causes this appearance, sort of almost like sausages on a string. And also this is, it's important to remember that these can appear in the eye and can be a significant level of ischemia. What do ERMA look like? So if you see prominent ERMA in 1 quadrant of the eye, greater than this 8A photograph here, use the red-free photographs, because that can actually help you find the ERMA. They're spidery appearing vessels at the terminal branches of the venules. They don't typically cross the major arteries or veins, and they appear quite flat on the retina. I always describe them as a sort of branching pattern. Think about a bunch of grapes with no grapes on it, just thinking of the branching. Notice that cotton wool spots do not appear in the classification for severe non-proliferative, but if you do have lots of cotton wool spots, look very closely for ERMA associated with them or adjacent to them on the retina. Then you move on to proliferative retinopathy. There's low risk and high risk. Remember, high risk characteristics. These are basically any neovascularization of the disc greater than 1/3 or 1/4 of a disc area. So if you see this diagram, the 10A photograph, so any more new vessels of the disc than that is classified as high risk characteristics for proliferative retinopathy. Or if it's less than that, it has to be associated with some pre-retinal hemorrhage or vitreous hemorrhage. Or if it's any level of NVE, here there's an example in the second photograph, that's greater than half a disc area if it's associated with vitreous or pre-retinal hemorrhage, and then that again would be high-risk characteristics. We don't wait for high-risk characteristics. We treat in London, even if you don't reach the high-risk characteristics. If you don't treat, this can obviously then result in fibrosis, traction detachment, and visual loss. Don't forget to look at the iris. It's very important, because if you have rubeosis, this is an eye that's extremely ischemic and can result in neovascular glaucoma with a very poor outcome. So don't forget to look at the slit lamp exam and look for rubeosis as well. Many of our residents say they can't find it difficult to differentiate between NVE and NVD and IRMA. So some clues here, if you use a red-free photograph, you can see here on the top right-hand corner, there's a sort of cauliflower configuration of the new vessel frond. It's a frond of new vessels, and whereas IRMA tend to be very flat, more branch-like. Another really good way of differentiating the two is using OCT imaging. You can see here the slice through the suspected new vessels show a branching vessels protruding into the vitreous cavity. So that's a very clear indication that there's new vessels there. Obviously, you can use fluorescein angiography, but we're using this less and less now as other modalities are more helpful and less invasive. Another example of new vessels here, you've got them protruding, breaching the ILM into the vitreous cavity. There's obviously OCTA now that's being developed. It's more useful for macular ischemia. It's not so helpful for routine diagnosis of NVE because it's not routinely wide field. However, wide field imaging is now becoming more common. So briefly going through risk factors, there's modifiable and non-modifiable risk factors, particularly the glycemic control. We all know from the DCCT and UK PDS studies, HbA1c should be less than 7%, or time in range, 70%, if those are patients on pumps. Blood pressure control, there's been recent hypertension guidelines from NICE, which are suggesting 140/90 for those diabetics under the age of 80. If they have renal disease, then it's even tighter, less than 130/80. Lipid control, this is interesting. There's no real evidence for statin use, but there is more evidence now for fenofibrates. And the NICE guidance recently published in the UK has now advocated that we should be starting type 2s on fenofibrates if they've got non-proliferative diabetic retinopathy. Interestingly, it should be prescribed by ophthalmologists, which could cause a few more issues. We'll briefly touch on drugs shortly. There's particularly the GLP-1 and the hybrid closed-loop systems. Pregnancy is another interesting one. The DIEP studies have shown that if you have diabetes for more than 15 years, or if you have more than mild non-proliferative retinopathy at the start of your pregnancy, you're much more likely to develop problems with proliferative retinopathy. And non-attendance is a big one as well. We did a study a few years ago showing that if you did not attend your appointment on 2 consecutive years, you had 10 times the risk of having a referable retinopathy at your next encounter. Non-modifiable risk factors, ethnicities are important. If you are African Caribbean origin, you're much more likely to need to have sight-threatening retinopathy and have maculopathy requiring laser. Duration of diabetes is important, but it's predominantly, which is why type 1s are more risk than type 2s because of the duration of the diabetes is longer. This is the document I mentioned. It's recently been published in August of this year, 127 pages, very, very comprehensive document about how to manage and monitor diabetic retinopathy, well worth a read. And it's very good recommendations. One of the things they mention is that anyone who's dealing with diabetes, ophthalmic interventions, you should have access to the stage of retinopathy, the HbA1c, the renal function, and the blood pressure, and also encourages multidisciplinary healthcare involvement and diabetology. We mentioned about these GLP-1 agonists and hybrid closed-loop systems. There is this worry that they could be worsening retinopathy because of the drop in HbA1c. We know from other studies that after pancreas surgery or bariatric surgery, up to 20% of patients can get a worsening, and this can happen within the first 3 to 6 months, and it's much more likely if you've got advanced DR at baseline. The SUSTAIN 6 trial also showed an early worsening, but after about 12 to 18 months, it seems to stabilise. A recent study from Stockholm disputes this worsening and say it may not be as bad as we think. But we're really waiting on the focused study, which will publish in 2027, and that primary outcome is specifically about progressive retinopathy and looking at anti-VEGF and laser outcomes in patients on semaglutide. So have to hold this space for that. So briefly, we'll hear more about this shortly. At the moment, when to start laser treatment, non-proliferative retinopathy, there's no consensus about starting PRP or anti-VEGF currently, not enough evidence. But with proliferative, because of the lack of long-term stability data for anti-VEGF alone, because of the need for multiple visits, risk of loss to follow up, risk of endophthalmitis, it's not currently indicated by NICE to use anti-VEGF treatment as first line. PRP laser is still the recommended first-line treatment for proliferative retinopathy due to its long-term effect. And this is the case even if there are no non-high-risk characteristics. So any PDR, you really need to be starting that laser. The laser should be carried out as soon as possible after diagnosis, ideally within 4 to 6 weeks of the diagnosis. And those with PDR, if you've got vitreous hemorrhage or significant cataract that is stopping you doing that PRP, then you can use anti-VEGF treatment as second line. And also if you have persistent PDR despite the laser, you can also offer your patients anti-VEGF treatment. But you're going to hear more about that shortly. So in summary, diabetes remains a significant cause of blindness in the working age population. Remember the classification, there's the AAO classification, and remember the definition of severe non-proliferative, which is the 4-2-1 rule, and 50% of these patients will progress to PDR in a year. Significant risk factors, we worry a little bit about the sudden drop in HbA1c, especially if someone's got high levels of diabetic retinopathy at baseline, pregnancy, non-attendance, and Afro-Caribbean. And there's no need to wait for high-risk characteristics of PDR before starting your laser. Vitreous hemorrhage or cataract may require anti-VEGF in the first instance. Thank you.
Thank you very much indeed, Sam. Does anyone have any questions about that? Please come up to the microphone if you do.